Dr. Fuster.
Thank you. Well, basically, I was asked to make a presentation of my meeting with the head of the Watson, who we had a debate a week ago about the future of what they are doing, and was a significant debate between technology and education. And I'm going to present to you how things went and how I see these enterprises, Google and then IBM, which works with Apple and so forth. Basically, my presentation was based, we had 8 minutes each. My presentation was based into what I think I see the future, which is we have to divide the population in different ages. We cannot just talk in general, because this has been our problem from the very beginning. The science of people between age 50 and 100 is completely different than subclinical disease between 25 and 50, and to the very early stages between birth and age 25. In the approach, this is basically science, and the educational tools to really have the receiver, the consumer, to change behavior is completely different depending on the ages. Now, here comes Google and IBM are very much concentrated here. And this is the first problem. And basically, what I will show you in a moment is how we are moving and how I see them moving. Their main interest has been cancer and brain. So cardiology has not been their main interest. And this came very open in the discussion with both, actually, with Google as well as with IBM. And I'm going to elaborate. Can you move this? Yeah. Can you take that? No. I just take it out.
Does that come out?
Yeah. You can. That's strange, but that doesn't matter. Well, here's the situation. What we are doing is, this is not supposed to be here, I don't know why. But what we are doing and what I presented is our approach. And our approach is basically to move from this stage, which could be age 50 to 100, secondary prevention in people who are rather stable, and we are talking about health rather than disease, to 25 to 50, which is people who are actually subclinical disease, and then to talk about the early stages. I don't know what happened with the slide. It's a little bit mixed up, but I will tell you their process. The TANSNP is a project that we try to work between age 50 and 100, is basically identify degenerative brain disease through imaging and correlate this with large vessel disease. And the imaging in large vessel disease is 3D ultrasound and calcification of the coronary arteries. And in the brain is certainly MRI and positron emission tomography. There's a lot of data, very strong data, suggesting that the same risk factors that affect the large arteries also affect the tiny arteries of the brain. And actually it's interesting because a paper presented here, the HOPE-3 study, is actually going to get into the brain and whether cognitive function in people with hypertension, in people with high cholesterol levels, can actually be improved or at least to delay the progression of this arteriolar disease with the use of statins and antihypertensive therapy. Is this paper has been presented here or not yet? The trial has been presented. Very interesting. In fact, 70% of the people didn't have hypercholesterolemia and they were not hypertensive. And those who had hypercholesterolemia and hypertensive, you can see the tremendous strength, how you can prevent the progression of the cognitive dysfunction. I'm just presenting this because the message is it doesn't work, when in fact, they are working with normal people. So this is a very important. The second project that we have at that age is the polypill. As you know, this polypill is the first one that has been approved now in 27 countries for secondary prevention. These are people with small heart attacks and strokes. And we have at this moment 3 prospective studies, not looking at adherence of a polypill better than taking all the pills following a stroke or myocardial infarction. We are looking now whether we can prevent recurrences of events. There are 3 projects now that we are having prospectively with the polypill. It is already approved, and I'm going to the FDA in 2 months for approval here in the United States. This is a combination of a statin, an ACE inhibitor, and aspirin. This is a second approach. This is in the elderly. Here comes, what I think you might be interested, is the projects that are between age 25 and 50. What our concerns are is subclinical disease, and can these people with subclinical disease change behavior if you show the arteries to them? This is the real question. And we have 3 studies now already published, which actually is a study of 12,000 people now, that we have with 3D ultrasound and calcification. And we are seeing very interesting things, and that is the predictability of subclinical disease, the burden of disease, is actually higher than familial. But this doesn't mean this is in a short period of follow-up. Why? Because the highest risk is to have the disease already. This is the risk factor that is the worst. So we will have that correlation. And this is one thing. Now the question is, can we change behavior? And this is really, it's a pity the slide really involves education is this. Can we change behavior? And what we are beginning to show is that the adults only change with the community. And that is working with the community is like a mental issue. You have to work in your setting, in your family, and so forth. Then you can change behavior. Otherwise, it's very difficult. And we have 2 projects. This is like Alcohol Anonymous, groups of 10 that help each other in terms of their health. And this is more directly to the patient. And this leads also educationally to the last 2 projects that actually are quite interesting is in children. We are now following 75,000 children. And all started in Colombia. All are randomized studies, by the way. There's no study I'm presenting that is descriptive here, none. So those in children, this randomization started in Colombia. And what we have found is between age 3 to 6 is the time to really the great window of opportunity. Whatever we teach to a child at last. We have now a 9-year follow-up with the Colombia project. We are looking at this. 3 years of follow-up, the intervened group is 70 hours of teaching health to these children, how the body works, exercise, how to control the emotions, preparing them to avoid the use of tobacco later in age. And our goal is at age 20 to demonstrate that what we did at age 3 to 5 has an impact. And this is now 75,000 children altogether that are in several parts of the world with different randomization types of progress. And now, since we have this would be the grandfather, this is the father, and this is the child. We have 2 main projects. One is the Familia project, which is in Harlem, 600 families, that we are doing exactly what I'm presenting to you, but in a family setting, to see which one of the processes, diagnostic as well as educational, has the greatest impact. And the other is in Mexico. The government of Mexico just called us 2 months ago. And basically, the Minister of Health wants all these projects in Mexico, all of them, as a priority of health in Mexico, moving towards health. I presented this, and then the new head of Watson is Deborah DiSanzo. This has been in Watson for 2 months, and was quite of a contrast, because what she really presented was huge amount of data. Let's say they look into an individual, in particularly 50 to 100, that's the problem. They are not going to much earlier. And they present a lot of data, genetic and so forth, and saying actually the robot is going to tell what is the diagnosis and what is the best treatment. That's basically what Watson is all about. Their main focus is cancer. And then now they realize that the brain is important and they want to get into imaging. They got into imaging by the brain, not because of the heart. And that's what they made this recent merger. So we presented 2 completely points of view, because that point of view is descriptive, but my point of view, can you go to the first slide? The previous one. I have the previous one. This is critical. This is my discussion, and that is, you can have all the technology in the world, but who is the receiver? These people can come with a fantastic technology, but it's going to be adherence by the patient, it's going to be reliability by the doctor, and they don't have any idea, which is where the educational process is failing in these companies. So I think what we achieve is, first of all, it appears that Google is coming back to us on the children aspect of education. And certainly IBM is very interested to really take what I presented to you on the left side that is very educational. And that is what tools could we use once they have all this descriptive data. So I have very little to say, but how this organization can really fit with all these other organizations, it has to be a significant change. I think and the change has to be on the educational side. You can present all the technology in the world, but if there is not really that this is not applicable to the patient in a very significant way, this will all fail. And therefore, I think what I'm really telling you, that if you don't have, you can have all the technologies that you want on imaging, but has to be an applicability, it has to be adherence, it has to be, this is basically what I got.
So you're saying even if we accomplish their goal, this massive job of identifying the characteristic of the vulnerable patient, and once we tell people that you're a vulnerable patient, whether they follow, they adhere, and how much of that translate to outcome is a question.
This has been a huge issue. Everybody talks technologically without taking into account the problem we have found in all of our projects is the consumer, the patient. That doesn't follow whatever you do. And I think this is really a critical issue. So I think that if you have to have an impact with these big enterprises, in my view, has to be on an educational side. Because in the technological side, they will listen to you, but we already have the technology. So I think that this is a critical, at least I give you the critical tool by the cardiovascular community has to be educational. Don't try to sell anything technologically because they will not listen to you. That's the way as I'm coming out from all of this.
Thank you. So, Dr. Fuster, when we brought this idea first for the One Brave Idea, one of the points that came up was that knowing somebody's risk, 50% or higher of event within 12 months can trigger actions. Whereas when you give people 20 years or 50 years or lifetime risk, it doesn't trigger. Psychologically, it doesn't trigger. If you tell them that in 30 years, you're going to have a 30% or 20% chance of event, versus you tell them in the next 6 months, you have a 50% or higher chance of having an event. That triggers psychologically actions and whatever else that we will have.
I don't know. It's very hard. It's very hard. I can tell you all of our projects that we have worked over the last 10 years, this has to do of what impact you have on the patient. It's very hard. And what we are finding is that the best receiver is the child. There's no question about it. It's the one that retains what you say and moves in the same direction that you actually made. And in the adults, one thing we are running, and actually we had, Samir was there this morning, there were 5 presentations about work of how to change the adults, all show the same thing through the community. If you don't have partners, if you don't have communities, we as individuals do not change.
I love your idea of family-based intervention.
Well, it's a critical issue.
Yeah, because, just like you said, usually there's mother in the family that takes care of, the man and herself and the children. If you focus on family and then provide this kind of actionable information, because if we just do the same thing that AHA or AACC have done for 50 years, we're going to get the same thing that they have got.
I think we have to change. I have to tell you, if we don't go into his or her brain, anything we can do will be descriptive and will fail. This is my view. That, when you realize in the freedom trial that only 20% of people with coronary disease and diabetes were taking the drugs they were supposed to take, 20%, we have a problem. Mm-hmm. And if we don't get into that, you can have all the technology in the world to try to solve the problem. You will not solve the problem. And this is what I see. And actually, she saw this very clearly. You should see the beginning of the conversation with her and the end. In fact, I'm meeting with her next week because now she wants to start working on the educational aspect, which is what these companies are really failing. So my advice to you, with all the technologies that you have, try to sell something that really can change, that can click into the patient, into the consumer. This is to me the key. Otherwise, these companies will not listen. This is my view.
Thank you. I think, Dr. Fuster, should you know, I saw a presentation in one of these, I don't know, it was IBM or something. They actually developed an app that takes a picture of the pill and takes a picture of the patient taking the pill and registers, and is a tool to improve adherence. So that 20% that you said in Freedom Trial is probably going to be affected by these kind of technologies.